Okay, welcome clinical problem solvers to Tuesday VMR. Really excited to be here today to discuss with David. And thanks to Simi and Patricia who are helping us out with scribing and teaching points. And we have Glenn back to present a case to us. He presented Austin and I a doozy last time, so really looking forward to his next case. Glenn, do you want to go ahead and unmute and introduce yourself to everyone?
Hello, everyone. My name is Glenn, just like Alec mentioned. I'm a medical student in Botswana. I'm doing my year 4. I'll be a final year medical student in a few months. I have interest in internal medicine. I'm about to prepare for my step 1, and then, yeah. Apart from that, what I like to do, I mentioned last time, I'm a Messi fan, so I watch Argentina, Barcelona. I also watch the Premier League. I'm a Man City fan also. Other things I like playing video games. I also presented a case last month here, and after that case, I had a chance to share it with my colleague, Dev. I think he has joined. So Dev, would you like introducing yourself to everyone?
Okay, thank you, Glenn. Evening, everyone. It's evening outside. My name is Dev, like Glenn mentioned. I hope I'm audible. I'm also a 4th-year medical student, like my colleague Glenn. He's my classmate. Yeah. I'm also interested in internal medicine, and that's where I see myself heading for residency. Thank you.
Amazing. Welcome, Dev. Really happy to have you as well. And yeah, really looking forward to the case today. So if we can get the whiteboard up and maybe we can get started with the first aliquot.
Should I go ahead? Okay.
All right, Glenn, whenever you're ready.
Okay, for the first aliquot, we have a 69-year-old male with a 3-day history of nausea and vomiting and a 1-day history of confusion. Further on to the history of the presenting complaint, he vomited twice per day. The vomitus was consisting of food content. It was non-bloody, non-bilious, non-projectile, and non-foul smelling. Is not associated with meals. However, associated with high carbs. There's also dark urine reported. Let me wait for the scribe. Yes, so like I mentioned, vomitus twice per day, food contents, non-bloody, non-bilious, non-projectile, non-foul smelling, not associated with the meals, associated with high carbs. There was some dark urine that is reported, however, no pale stool. For the confusion part, I was able to give some history, so there's some limitation to getting the history. Sometimes I would give some inappropriate words. So some rest of the history got it from the daughter. From the daughter, managed to get that they didn't get any exposure to untreated water, any seafood consumption, any recent travel. Yeah, I'll stop here for the first aliquot.
Okay. Thank you, Glenn. So with this chief complaint, I think my first reflex thought is to center more on the confusion that in the nausea and vomiting, because I think nausea and vomiting are more unspecific symptoms that can be in a lot of different systems and do not localize many times to a particular system. In this case, being the confusion, yeah, I think that the most specific chief complaint, I would think in CNS pathologies that could also cause nausea and vomiting, such as intracranial hypertension. There's also some diseases affecting the area postrema. Well, there are specifically, for example, NMO that can make a lesion that, but some toxics could cause also like more pronounced affectation in that area and could also cause nausea and vomiting. I don't know. For this moment, Glenn told us that the nausea and vomiting were not projectile. That is a feature that we tend to associate with, for example, meningitis or yeah, maybe more CNS pathology. But confusion could also be from the other aspects of the missed mnemonic. So maybe this could be, I don't know if this could be a clue to a toxic metabolic etiology more than a CNS. But yeah, I think I would initially frame as well, middle age or tend to more elderly patient with confusion with AMS. And the nausea vomiting doesn't tell me for now a lot. Makes me a bit more inclined to toxic metabolic and also for the possibility of intracranial hypertension. But yeah, this is my first thought. Regarding the dark urine, I think we first of all have to make clear what is that. Like, is this hematuria? Is this rhabdomyolysis or any other lysis, hemolysis or something like that? Yeah, I would. And this could be a red herring that is a no significance. So yeah, what do you think, Alec?
No, I love that, David. And I love your thoughts about really trying to figure out, is this a primary CNS process or a secondary CNS process? And so I think the background is going to really provide additional insight into the foreground. So we have an acute sort of nausea vomiting syndrome. And you're right, nausea vomiting in and of itself can be nonspecific. And I think the age is just really interesting here. Like if this was a 19-year-old with nausea, vomiting, certainly we'd be running in confusion. We'd be running towards the CNS, right? But he's 69. And so I think a lot of times in those situations, frequently the altered mental status is secondary to whatever other systemic process is driving this. So it'll be interesting to learn what sort of past this patient has, what other risk factors for infection they have, and what else could be going on. I agree the projectile nature of the vomiting doesn't necessarily inform me too much. But it's going to be really trying to localize what other symptoms this keeps. Like, is the patient having abdominal pain? Do they have headache? Is there something else that's going on here that may inform us to where this syndrome is truly living? And I think we're just waiting for additional clarity on that. And just to add on as well, I totally agree with you. The dark urine, I don't really know what to make of that. Really could just be volume depleted and the urine is just concentrated. And that's, I think, my first thought. But I think the labs and the additional history will give us more information there. And then I think finally, just clarifying the time course a little bit more. What came first? Was it the confusion and then the nausea and vomiting, or was it the nausea and vomiting and then the confusion? Because I think although there may be some overlap there, if the nausea and vomiting began before the confusion, it made me think more of something extra CNS, although certainly doesn't include a primary CNS process as well. But otherwise, I don't really have much to add. I think that was an excellent first thought. And yeah, Glenn, let's hear the next output.
Okay, thank you for that. Just to go ahead and answer your question. So what came first is the nausea and vomiting. Then after 2 days, that was the confusion that came. So for the next allocate, starting with the review of systems, musculoskeletal, no bony pains, there was no palpitations, no shortness of breath, or cardiovascular. The rest of the other systems, nothing was remarkable for the pulmonary, no cough, chest pains. It was neurovascularly intact. No rashes for dermatology. For the past medical history, though, he has a past medical history of diabetes, which was diagnosed in 2011. For the complications, it was complicated by gastroparesis and also erectile dysfunction. For the treatment, he's on Actrafane. So Actrafane is a combination of the long-acting and the short-acting. So it takes 3418 the dose. So it consists of Actrafane consists of short-acting insulin and NPH. For the control, by HbA1c is 11% at the moment, which is very high. Another comorbidity that he has is hypertension. For treatment, he's on amlodipine, 5 milligrams once a day. He's also on hydrochlorothiazide. Yes, and for the hypertension, no known complications at the moment. Also, he has a history of PPI use. He was admitted prior to this and was given PPIs. So I was admitted for epigastric pain and was given PPI for the previous admission, which I couldn't get the timeline for it because of the confusion and all that. So moving on, so the past physical history is unremarkable. Social history is a security officer, married with 5 children. He's of sober habits. He doesn't drink alcohol, doesn't smoke. Has no history of exposures like working in the mines, like chemical exposures. For the family history, it's unremarkable also. I'll just finish this allocate by talking about the vitals in the physical exam. So the vitals, many of them were abnormal. The blood pressure was 155/83. The pulse of 138. Saturations of 88 on room air. However, it improved on oxygen. We give face masks 4 liters per minute and it improved to 95. The respiratory rate 27. Temperature 37.5 degrees Celsius. The RBS, random blood sugar 308.1 milligrams per deciliter. He has a BMI of 29. Yeah, that's all for this allocate.
Well, Glenn, another excellent breakdown and thorough history, and I really want to commend you well for your pace as well, letting the scribe catch up. It's not easy to do, so I really appreciate that. So, yeah, I'll just give my first pass thoughts, a little bit of the past medical history, and then David can let you add on to anything on that and what you think of the vitals in the exam as well. But as far as the additional review of systems, really not much. I think it would have been also interested to know, does the patient have any headaches, any photophobia, any specific generalized abdominal pain, or is it just isolated nausea and vomiting? And then if there's any fever or chills that the patient had experienced previously. So those are things that I might go back and just ask. But I think before I dive into additional things, just the past medical history of diabetes is really informative here, just because anytime that we see diabetes with nausea and vomiting, particularly in a patient that's ill, certainly DKA is one that comes to mind as a no misdiagnosis. So that would be something I would be certainly entertaining. And in addition, it seems like this patient has already developed cardiovascular consequences of the diabetes, in particular erectile dysfunction. And he has other cardiovascular risk factors as well with the hypertension. So certainly nausea, vomiting with an acute syndrome wouldn't want to miss something cardiac going on in particular, like ACS. So certainly this patient would benefit from an EKG, I feel also. And history of gastroparesis could explain some of the nausea, vomiting without this clear abdominal pain syndrome, but the vital signs that David we're talking about, unless he's profoundly volume depleted, are certainly more concerning. And otherwise he seems to just have developed kind of sort of metabolic risk factors throughout his time course. And yeah, as far as the medications seem fairly appropriate for someone with his medical comorbidities. I'm not certain what the PPI indication was, if that was just for GERD, or if he had a new diagnosis of H. pylori, or if he had a GI bleed or something else happened. So I know sometimes we didn't get the history, and it seems like maybe that's something that will prevent itself later or be unrelated. And yeah, I mean, I think in addition to the other medications, I think he was on HCTZ. Whether or not that could predispose him to other electrolyte abnormalities that might make him a little bit more confused would be something else I would be considering, because I imagine the patient's fairly volume depleted with nausea, vomiting, significant polyuria from the uncontrolled hyperglycemia, and then some of the medications that he may have continued to take during this time. So I think those are my thoughts on some of the past medical history and how they lay in. But David, what do you think, and what are you thinking about the vitals?
Yeah, I agree. I think the main thought that I think comes to everyone's mind with this presentation is DKA. It seems to be a long history of diabetes with poor control, at least for the last months. And the vitals here, I think the tachypnea could be justified, for example, but by an acidosis if the patient had this hypothesis to be confirmed. And the hypoxemia, yeah, and mild fever could be a lot of possibilities, but first thing that comes to mind as most likely in the setting of confusion is an aspiration that could account for that. I would want to see if this is sinus stack or not, but I think I'm framing it more as a qualifier of the severity of the syndrome more than a feature that would give us any additional information likely. But well, let's see an ECG and let's see what finally ends being. I think that the caveat here is when you have DKA. Yeah, first of all, you usually think of patients more young, typically type 1 diabetes. Also, although there can be, of course, decay in patients with type 2 diabetes, type 2 in the setting of pretty prolonged history and with kind of insulinopenic reserve. The fact that the history that the glucose that we're seeing here is 300. I'm used to see more more severe hyperglycemia in the setting of DKA, although they tend not to be as high as in hyperglycemic hyperosmolar state. But I think it can be definitely seen decay also with this glucose. This patient is not on a SLG2 inhibitor, but there are also other other conditions that could prompt to have that ketoacidosis with not so high glucose, such as if this patient was starving for a few time or is septic or have any abdominal pathology like pancreatitis or something like that, that could make a picture of ketoacidosis have no such a higher glucose. And yeah, I think I want first of all ketones in the blood. I've recently seen through in Twitter that in some institutions they are not like very available and to get in the blood. But I think it's it would be here and in the if we suspect DKA, the ketones in the blood are much more useful than ketones in the urine. I've remembered that after reading the recent NAM case that I don't know if you have read, but when you have normally just to make that piece of learning, you have normally a ratio of acetoacetate and beta hydroxybutyrate like being 3-1, favoring beta hydroxybutyrate. But in the setting of DKA, you should get the ratio turns to be around 10-1, favoring beta hydroxybutyrate, and the ketonuria also only detects the acetoacetate. So yeah, trying to get a ketones in the blood will help us. Yeah, I think we have to see if everything points towards that direction, but this is a pretty non-specific syndrome that could be many other things, including sepsis and other toxico-metabolic syndromes. But it's good to have the information that this patient doesn't drink alcohol or apparently has no ingestions, but the history could be very, very affected by the confusion of the patient. So just keeping that in mind. Yeah, do you want to add anything, or we can pass to Glenn to take us more?
No, nothing to add. Feel free to take it away, Glenn.
Okay, let me continue. Thank you for the discussion. So for the next allocate, so I will continue with the rest of the general examination. So for the general examination, he looked ill looking, was alert. His GS was 13/15. Because of I would tend to show signs of confusions there. I was seeing mild respiratory distress on face mask. There was some signs of conjunctival pallor, some tinge of jaundice. There's no lymphadenopathy. Was mildly dehydrated. So on the system of interest, the abdominal exam, I mentioned jaundice. So, however, there was no signs of chronic liver disease. However, the abdomen was soft. There was some right upper quadrant tenderness with no Murphy's sign. No masses in the abdomen. The liver span was normal. No splenomegaly. Was tympanic to percussion in the abdomen. There was normal bowel sounds. Other systems, the respiratory system was in mild distress, tachypnea, like you saw in the vitals. There's no chest deformities. The chest was symmetrically rising. The trachea was midline. On percussion, it was resonant. It was decreased breath sounds bilaterally, but it was more on the right than on the left. On the cardiovascular, nothing much except for the warm peripheries. He had a capillary refill time of normal. He had normal S1, S2, no murmurs, no added sounds. Neurologically, the GCS was 13/15 because of the inappropriate weights. However, there's no other signs of neurological deficits. So moving on to just the initial investigations that we did. So following the discussion that you guys had about the DKA, so I'm gonna start with the ABG findings. So for the pH was 7.52, partial pressure of O2 was 81, of carbon dioxide was 31, the bicarb of 18. We then did the urine dipstick, but however there was no ketones in the urine, surprisingly. Yeah, I wanted to add that because of the conversation that we had. Then let me continue to other initial investigations. So for the full blood count, the WBC was elevated at 28.9, predominantly neutrophils at 25. The hemoglobin was 8.5. The baseline, however, is higher than that. It's around 10, the baseline. MCV was 88.9. The platelets was low, 48. The liver functions shown an increase in ALT, ALP, and GGT. We then calculated the R factor, which was 0.5, showing a picture of a cholestatic picture. And then also the bilirubin and the total bilirubin was also elevated. The proteins and albumin, total proteins was slightly low at 5.8 grams per deciliter. So this is like most of my units, grams per deciliter. The INR was 1.06. Just to end this, allocate with the renal functions. Sodium was normal at 140, potassium normal at 3.9, urea was normal at 15 milligrams per deciliter, creatinine 1.1 milligrams per deciliter. Yeah, that's all for this allocate.
Okay, so I can take the DXM, and if you want the CBC, and I'll let you discuss the rest of the BMP and that. For the DXM, well, the jaundice, I feel is a very concerning finding here. First of all, because in a patient with jaundice and delirium and encephalopathy confusion, as you want to call it, first thing that comes to mind and that I think needs to be excluded is severe liver failure that could account for that. In this case, with the jaundice and the right upper quadrant tenderness, we tend to probably localize the problem more to the liver than to prehepatic hyperbilirubinemia, and in that setting, yeah, the confusion is very concerning. What can be the cause of the jaundice here? I think there are many possibilities, but specifically infections and viral infections are the one of the main things that we have to exclude, given the acuity of the syndrome, and that we're not seeing any ingestions that at first that could account for an acute hepatitis. And this patient is not in shock that we're seeing for now. So the possibility of ischemic hepatitis is very, very decreased also. That have to be excluded, but doesn't seem to be for the history now. Infections are one of the main possibilities, given that also the possibility of biliary cause, I feel it's decreased by the time course and the pronounced confusion that the patient had. Cholangitis could be one of the possibilities here, also with the white blood cell count, because with this neutrophilic picture, we are more inclined to think of bacterial infections than viral. The bacterial infections, I think, yeah, Ravi tends to divide it in a way that I love a lot. That is like external versus internal, and I think thinking of internal, the main possibility here would be cholangitis, because cholangitis shouldn't cause this jaundice unless complicated by Medici syndrome or yeah, other possibilities that we discussed in the chat sometimes. But yeah, cholangitis has to be excluded at first, I think. And there are also the possibility of exogenous infections, of external infections affecting the liver could be at play here. For example, leptospirosis and Wales syndrome is one of the ones that I think at first, and this also can affect the other like give a systemic picture that we similar to what we are seeing here. Aside from that, yeah. There are other bacterial causes that could cause hepatitis, for example, and also with a pulmonary feature like Q fever, for example. But we don't have at least a pronounced pattern history for that, and I think this is maybe too fast for that. I'm not sure, but yeah. That's one of my thoughts. For viral hepatitis, this could be a possibility, but the white blood cell count, I think, decreases that possibility. Not only for for example, hepatitis A or hepatitis E that are one of the most acute ones, but also for other viruses that can cause hepatitis, such as HSV, VCV, CMV, EBV. All the herpes virus can. Yeah, I think these are not the main possibilities here. With the anemia and the thrombocytopenia, we could think that this could be just in the setting of the sepsis picture that we're seeing here, and I think this would be probably the main possibility in, for example, in my setting. But I don't know if in the country where this is happening, other viruses and other other infections that we have to keep in mind are, for example, malaria and I don't know if other hemorrhagic viral illnesses that could be at play. Yeah. I'll leave you there to discuss VMP and tell anything that I missed.
No, David, you didn't miss anything. I think I may have missed part of it because I think I froze for a second, but that was awesome. So I think just to add on, yeah, I mean, I think in short, this is a older gentleman with a history of uncontrolled diabetes who's coming in with an acute syndrome characterized by nausea and vomiting, and was found to have sepsis with really localizing signs on exam to the hepatobiliary tract for the most part, with jaundice and right upper quadrant tenderness. So I think with the clinical presentation and the depth of the neutrophilia, certainly like a pyogenic infection in that area would be of highest concern, in particular cholangitis. And I loved your point that just cholecystitis alone should not give you hyperbilirubinemia, especially if it's from stones. If you get choledoco associated with it, it can. And occasionally, acalculous cholecystitis can cause some liver chemistry abnormalities, the mechanism of which is sort of cytokine and hand wavy. But and patients with that can get very, very ill. But I think the diagnosis you would definitely want to exclude first would be cholangitis. So hopefully we'll have some, either a CT scan or an ultrasound, preferably a CT. But oftentimes we start with an ultrasound to really investigate that further. And then, I think trying to incorporate from the exam the decreased breath sounds. The patient is hypoxic, and I sort of am on the same wavelength as you, David. Is I'm sort of just ignoring it for now and solving everything else because I'm just blaming this on aspiration and moving forward. But I think your thought of whether or not there could be a viral hemorrhagic illness that sometimes can lead to third spacing or other primary pulmonary pathology would be certainly a consideration. So we'll get our chest X-ray and monitor that and see if that shapes out. But just something that I'm tracking as well, but maybe just putting a little bit lower on my priority list, as long as he doesn't develop frank respiratory failure in the near future. As far as the blood class, we don't have the full BMP to calculate the anion gap, but to me, this is just mostly a respiratory alkalosis. And the PCO2, I mean, I imagine he has a lactate with the degree of his sepsis and hypovolemia likely. And so I imagine that the bicarb, it's a little bit low, but it's not really all that concerning to me right now. But I think a full BMP to sort of interrogate that further to get the anion gap and everything would be nice, but just another consideration. And then the kidney function, the creatinine 1.1, it would be really interested to know what the patient's baseline is. I imagine this is probably above the clinical presentation. And I think that feeds into the CBC abnormalities as well, because certainly the anemia and thrombocytopenia could just be worse in the setting of bone marrow suppression, in the setting of sepsis, or whatever organism could be driving this. But the depth of the thrombocytopenia is also fairly profound if we're assuming that his platelets are normal at baseline. So I think that's something that would be important to know as well. Because certainly really bad bacterial sepsis can cause it. I've seen Staph aureus bacteremia do it, just bad GNR bacteremia in general, but 48 is pretty low. And then one of the other infections that Robbie has mentioned a few times that can cause, significant bacterial sepsis and thrombocytopenia is Lemierre's. So that would be not really getting a signal for that, but just something I wanted to mention. And then because I often forget to say this, I think really defining the other immunocompromising conditions that this patient may have will be paramount, including HIV. So if we don't have that, I think that would be important to get as well. The liver chemistries, seems like the AST is mildly elevated. I'm not sure how high the ALT is. And the bilirubin, if I'm seeing correctly, is 3. So elevated, but not, usually you need 4 or more to get jaundice. So I am wondering if that's going to sort of work its way up, or perhaps it was a little bit higher. But something I'm tracking as well. And then, like you said, yeah, the combination of the anemia, thrombocytopenia, the jaundice, certainly I would be thinking about malaria. And then some of these infection as well can also predispose you to other concurrent pyogenic bacterial infections as well. But I definitely would be primarily concerned about those things. And, in addition to investigating the things further with blood cultures and starting empiric antibiotics, I think a peripheral smear as well to rule out potentially malaria. But if the patient does have a kidney injury and has sort of a hectic syndrome with anemia and thrombocytopenia, just being sure that we don't have schistocytes or something that could be concerning for a TMA as well. But yeah, I really love those thoughts. The patient is very ill, and we need to figure out what's going on. But I think running towards ruling out cholangitis as being the most life-threatening and treating appropriately until we can do that, I think is what I would be doing next, and kind of taking things from there. Any additional thoughts to add, David?
No, and I think one thing that we haven't thought about is that the pretty poor control DM predisposes this patient to severe infections. That is a thing that we have to keep in mind. And first of all, yeah, I agree with you. I think if I had to think of the first thoughts, the first things I would do in the ER is probably getting a smear and LDH and trying to figure out if this is a hemolytic picture or not. And if this is not a hemolytic picture, that would make more likely also, for example, malaria or yeah, another an exogenous infection. I would well I would go at the same time for an ultrasound, the abdominal ultrasound, to rule out the dilated biliary duct. And if the ultrasound is doesn't give me a clear picture, I would go for a CT, because I think this the ultrasound can have some false negatives in these settings, and it's not the first time that for example, an hepatic liver abscess is also missed by an ultrasound that can be seen on a CT. And with this, if this would have been cholangitis, this could also complicate by, for example, having liver abscesses. So yeah, this is the first things I would do. And I think also, yeah, starting antibiotic and began the antibiotic therapy that I think, I don't know, this patient is I think clearly septic, although not hypotensive. So I could go, for example, for PEEP TASO, and just to cover the possibility of enterococci. Linezolid is another thing that would have in my mind. Yeah. Glenn, what do you have for us?
Okay. Before moving to the next allocate, so we basically had a similar differential diagnosis before we started the imaging and rest of the diagnosis. So we worried about the infectious source, so we did infectious workup. So wait. So for the infectious workup, we did the blood MCS, also the urine MCS. Both of them, there was no growth after 5 days. We also did check for TB. So we did the sputum gene expect and the urine LAM, they're all negative. We did the serologies. So rapid HIV test was negative. RPR was non-reactive. Hepatitis B was negative, the serologist. And then we did amoeba serology as well, which was negative. We also did malaria, rapid antigen test for malaria. So we sometimes get cases of malaria here and there in our country, but it was negative. The rapid malaria test was negative. And then, yeah, that was it about our the infectious workup. And then we went on to do chest X-ray and the abdominal ultrasound. Let me try to share the screen to show the chest X-ray and the.
Glenn, would you like to share, or do you want me to share? I can do it as well as you prefer.
Oh, okay. Yes, you can share only the chest X-ray and the abdominal ultrasound.
Okay, just give me a minute, please. Absolutely.
Okay, that's the chest X-ray. I don't know. I think I can just leave it here. For this allocate for the chest X-ray and the abdominal ultrasound, you can interpret them from here. Then the last allocate will reveal the diagnosis with the last images.
Okay, amazing. Yeah, we could see the X-ray. And Glenn, you wanted us to discuss ultrasound as well? If so, Simi, we might need to see the image for that as well.
Yeah, fully after this will be the ultrasound, the abdominal ultrasound.
Okay. Yeah, so I guess while we're pulling up the ultrasound image, I can just comment on the things we have so far. So the blood cultures and urine cultures are negative, which is I guess nice, but not reassuring that the patient doesn't have an infection. And then the TB test, HIV test, malaria test are all negative. And it seems like probably, there's a bunch of different types of malaria. And I assume that the antigen test for the types of malaria that may be prevalent or more prevalent in your country. And presumably those are, I actually don't know the test characteristics to know the, sensitivity of those tests, but I imagine they're quite good. So I think we can rule those out. I think the chest X-ray is very impressive. Patient has, bilateral infiltrate, certainly more on the right side. Don't seem to be more consolidative, more which I imagine on CT might be ground glass. In the sort of right upper lobe heading towards the middle lobe, maybe it's probably just some shadowing from the rib, but there's a little bit more hyperdensity there. But I think, if I was in the US, I would just probably get a CT scan to better define this. But I think with the severity of the patient's illness, either this could just be a secondary ARDS potentially related to the severity of the infection or wherever that's coming from, or if there potentially could be another either pulmonary component to whatever's causing the abdominal syndrome. Or if there's some other infection that could be spreading throughout the body as well. It doesn't seem like the patient had a lot of JVD or edema on exam. Certainly you could consider pulmonary edema as well, but I think the clinical picture is a little bit less consistent with that. And then now we're seeing the ultrasound. I have some thoughts on that, but since I talked about the X-ray, David, do you want to comment on any of that and what you think about the ultrasound?
Yes. Well, very impressive. Actually, I was not expecting that. I I initially attributed the hypoxemia and tachypnea to the to a probably aspiration. I think this is not the case. And this is a very interesting space because I think not so many diseases have thoracic and abdominal features at the same time and in an acute manner, because there are many granulomatous infections and all of that could have, for example, hepatosplenic involvement and also pulmonary involvement. But if I think in acute infections that resemble that are, we mentioned the three, I think, likely that leptospirosis. This patient, the creatinine was normal. We don't have a specific history for this, but I would definitely check it. Q fever is the other possibility that came to mind, but I don't think this. I feel this is a bit acute, and this patient is too sick for being Q fever. I don't have experience with Q fever because I haven't seen any case for now, but I feel I feel there is too much acute and sick patient for this, and also the hypervirulent Klebsiella pneumoniae came to my mind because of the possibility of liver abscess and pulmonary involvement. I think this is much more described in South Asia, but don't know at all if this is a possibility in Botswana. If the blood cultures were negative, I think this could be decrease the possibility of this, but I think I would like to probably drain that abscess. That seems to be an abscess. Maybe maybe it's not, but I think I would probably like to drain that abscess and trying to see if the pathology give us a clue. The possibility of also being this a liver infection with secondary ARDS for the sepsis picture is also very very possible here. But yes, what other infections come to your mind, Alec, when you think of pulmonary involvement in an acute manner?
No, I absolutely love the thought. I think that I had the same initial thought as you, as whether or not this could be hypervirulent Klebsiella. I think the presentation and the sort of the rapid multi-organ involvement could be very suggestive. And I think there is more community prevalence in Southeast Asia, but I've seen it here a couple of different times. So I'm not really sure what it's like there in Botswana, but that was my primary consideration. The other thought was, the blood cultures are imperfect. I also don't know if they were done after the antibiotics. So, could this patient have endocarditis? I think that would be something that we could consider. And I think the other thing in regards to the what looks like a liver abscess there is they're so hyperinflammatory that you can get clots that form with them. So if this patient ended up having like a hepatic vein thrombus, for example, that got infected, and little pieces of that were breaking off and then going into the heart and then into the lungs and causing septic emboli there. That's something I've seen one time, and I guess theory could explain some of the pulmonary findings if the patient didn't have endocarditis and they didn't have just sort of sepsis-associated ARDS, or the patient has a lot of risk factors for diastolic heart failure. So I don't know too if they could have just had some edema there. But as far as other organisms that can cause a syndrome to progress this rapidly, I would still be thinking it's mostly the enteric gram negatives for the liver abscesses here, with Klebsiella being the one I would associate more. But beyond those, certainly parasitic diseases could link both of them. But I don't typically think of them causing such like bad sepsis. This just like really is really evocative of a primary pyogenic infection, and so it's really hard for me to escape that. So beyond the enteric gram negatives, in particular like the hypervirulent Klebsiella, I'm not exactly sure. And maybe there's some other hypervirulent virulent gram negatives that would be a consideration. But yeah, I would be really interested to better define the pulmonary findings that we see on the chest X-ray, whether a CT would help us figure some of that out, or I'd just be bringing the ultrasound. Is this all just interstitial with the B lines, or does he actually have some focal, consolidations or whatnot? But I think as far as next steps are concerned, continuing on those empiric antibiotics, and then I definitely think that if we can, or if the blood cultures happen to come back positive later on, that would be helpful. But I think draining the liver abscesses would be where to go from here. And yeah, any final thoughts before we send it back to Glenn?
Yeah, no, I agree with you. I'm also thinking one of the main risk factors for hypervirulent Klebsiella pneumoniae is also diabetes. So this also goes for that picture. And I'm thinking what is the possibility of like other disseminated infections like hematogenous infections that could affect both liver and pulmonary infections. But as the hepatic the liver abscess usually is from an abdominal source, like it ends up being there for the drainage of the portal system. In most instances, the liver acts as a filter to prevent that for going to the lungs. And as you said, for example, in the schistosomiasis could cause liver involvement, and these parasites could dislodge and also go to the lungs and cause like mild chest opacities that tend to be peripheral. But this is not a picture for schistosomiasis. It would be much more subacute or chronic. Yeah, and I think there's no more things that comes to my mind. Yeah. The possibility of ARDS is yeah, it exists, but aside from that, I don't have much more thoughts. So Glenn, please explain us what did you find, and yeah, I don't know if we get into the final aliquot.
Yes, so while interpreting the ultrasound and chest X-ray, we had basically the same findings. So we went ahead to do further imaging, CT of the chest and CT of the abdomen, just to wanted to confirm the findings. So maybe Scribe can show the CT findings. That will be the end of the last allocate, and then I can go through our clinical course and treatment, how we then further on to manage the patient.
Excited to see these CT images.
Please.
Simi, we could do one still image, but I don't know if is it a video, Glenn, that you had?
Yes, it's a video.
Okay, I don't know if you go back to the first slide, Simi, and see if you can like double click on it and see if it plays or not. But
Yeah, like I also remember I posted in the chat. Melioidosis is a disease that I think it's a bit similar to hypervirulent Klebsiella pneumoniae in the setting in the meaning that it can also cause very disseminating infection. I think this is also much more common in Southeast Asia than in other parts of the world. But do you know if this picture could work for that, or?
yeah, that's a great call. I've never seen a case of melioidosis. From what I understand, it's frequently like can be sort of enters the body through the same sort of pulmonary like the endemic mycoses and TB and whatnot. So I would imagine it would be more of like a primary pulmonary syndrome that spreads to the rest of the body, but I just don't have a good handle on the illness script. There was like a few case reports because it's a very uncommon infection in the US, but there were some candles that were like contaminated in a Walmart, and a bunch of people ended up getting infected. And I think it got published in the New England Journal. You could look that up. But I don't remember a lot of liver abscesses, but I'm just not super familiar with it. So I'll have to look that up and get back to you. But I think we're maybe having some problems with the images, which is totally okay. So Glenn, do you mind just kind of walking us through what the read was of the CT findings?
Okay. So with the CT of the abdomen and of the chest. So starting with the CT of the abdomen, we just confirmed from what we saw with the ultrasound. So we saw a hepatic abscess. So to confirm the hepatic abscess and with associated peritonitis, but then the patient didn't have any clinical signs of peritonitis. For the CT of the chest, it showed a septic emboli. Also showed a right upper lobe pulmonary embolism. Yeah, that's basically what. The two main findings: septic emboli and the right upper lobe pulmonary embolism. Then we came to a diagnosis of a hepatic abscess, but we had a challenge of trying to identify the source of the infection. So we're thinking it is probably secondary to cholecystitis. So hepatic abscess, probably secondary to cholecystitis, and then complicated by sepsis, which you saw, and septic emboli on CT chest. So that's the diagnosis that we came about, and then we did. We started the patient of on IV antibiotics. Actually, it was before the diagnosis. So we gone for, just like Mark said in the chat. So Mark mentioned somewhere about the antibiotic of choice for this kind of scenario. But for us, we're going for ceftriaxone and metronidazole. And then the patient improved on that, and the confusion improved as well. For the abscess, we sent the patient to hepatobiliary surgeon. We referred for either incision, for incision and drainage and possible cholecystectomy. So that's it for the last allocate.
Okay, thank you so much, Glenn. Just an amazing case, and definitely I have to read more on it because yeah, what did the main my main thought here is if this is septic emboli, from what is the source of the emboli? Many times can be or septic thrombophlebitis anywhere, or endocarditis. If this I think if this patient did not have endocarditis, that I don't know if a TTE was done, but if this was not the case, would have to look up for septic thrombophlebitis. But if this was a Lemire picture in the jugular vein should be symptomatic, and I think less likely here. There can be also Lemire syndrome from the abdominal veins. Some of there is a possibility here, but yeah, I think I don't know if the CT should have found that. But and if this was endocarditis, that would explain, for example, right-sided endocarditis, the septic emboli to the lung. I'm having trouble to correlate that with the septic the abscess in the liver. So yeah, I'm not sure. I think I think the liver may be the primary source here, and not sure how it went to the lungs. But yeah, I think that is my main thought here. I have to read a bit more on it.
No, what an amazing case and great reflections, David. So yeah, I mean, I guess my primary thought would be, if the patient doesn't have right-sided endocarditis, would be whether or not they had, a hepatic vein thrombus that was, showering emboli up. But, I'm not sure if the imaging, like there was a Doppler or if that was commented on in the CT. I guess from what my understanding is that abdominal lemurs is definitely described, but I think more common with the portal vein. So really the liver should be sort of filtering out some of that more. I'm not sure if they were like, if around the abscess, if in theory there were small enough clots that were slowly breaking off in the venous system and then heading up to the lungs. I guess in theory that would be possible, but I would definitely have to read more on that as well. But I think the organism would be interesting to know as well. And I'm not sure, I think Glenn said that the patient was going to go for a cholecystectomy, like whether or not, if anything ended up being cultured or if the gallbladder was actually inflamed on imaging. I mean, I think sometimes in these patients that I've had liver abscesses in the past, sometimes they just get transiently bacteremic and they can seed the liver and that leads to problems, or they just end up being, they have some like chronic cholecystitis and that predisposes them to get a liver abscess, or, maybe he had gallstones and had transient cholangitis and that led to a liver abscess. Sometimes it's a little bit hard to figure it out clinically, but yeah, what a really interesting case. And the septic emboli is it's a really interesting twist to the case. That's something I'll have to think about and reflect more. But yeah, Glenn, I would love to hear your sort of final reflections on the case.
Okay. Thank you, everyone. I think I really got to learn a lot, especially with the everyone who commented on the charts, and also you, Alec and David. So we had some challenges also on the case, just like proving the bug itself. We couldn't do that. Maybe I think for our main challenge, our side here is we have limited resources. So like whenever we have like a certain differential diagnosis, we'll just do. We don't have the luxury to do everything, but we do like the most likely, and then some diagnostic we might not have the luxury to do them, but for this case, we managed to get the abscess, and then the fact that it's hepatic source, with the possibility of cholecystitis, and I really learned a lot with how the other differential diagnosis it could have been that we missed while we were going over the case at Marina. So thank you everyone for the contributions. Yeah, that's all.
Glenn, awesome job again. Thank you so much again for taking the time to put this together and to be so thorough and to, share this case with us. There was a lot of learning from it and a lot to gain from, your perspective practicing in another country that, I don't have a lot of experience with what resources are available and not available. It's easier for me to just be like, oh, order this CT or that MRI or whatever, but frequently that's not practical. And I think you guys are true clinicians to be able to do things with more limited resources. So I really applaud you for that. And yeah, Patricia, I guess we can pass it to you for the teaching points.
Okay. Hi, everyone. Thank you so much for this great discussion. Thank you, Glenn, for bringing the case. So from what I gathered, we started talking about the chief complaint was nausea and vomiting. And so we started our discussion with the idea of nausea and vomiting. That is usually a non-specific symptom that can also be a clue for CNS pathology like meningitis or intracranial hypertension or some toxic infection, toxic abuse. Also, we need to think when we have AMS, we need to think, is it a primary or secondary process? We need also to look about associated symptoms like abdominal pain. So with confusion and automental status, we have our mismnemonic from different etiology like metabolic infection, sugar, or toxin. Here, our patient has diabetes, and when we see diabetes plus nausea and vomiting, it's important to rule out DKA. True DKA is usually seen in much younger patients, but high glucose is not necessarily from diabetes, but it might be from other causes like starvation state, septic state, pancreatitis, or other causes. And when we see like hypoxia and confusion, it's interesting to rule out aspiration. So in our case, our patient presented with jaundice and confusion, which can be a sign of severe liver failure. And severe liver failure might have multiple etiology like viral infection from different hepatitis, or it can be caused by ischemia, which is usually associated with shock symptom. And from external sources, we have cholangitis, which can be a clue with the elevated white blood count, or some bacterial infection like leptospirosis or an ulcer from systemic infection. Anemia plus thrombocytopenia is important to think about some kind of infection. And in this case, since we had like involvement of the thorax and the abdominal, and the abdomen, we talk about some bacteria that can cause both. So we had a discussion on Q fever, Klebsiella, some parasitic disease, and also endocarditis might be a cause. But usually liver abscesses are usually from abdominal sources. Okay, but because of the internet, I lost a lot, but that's all I was able to gather for this quiz discussion. Thank you, everyone.
Thanks so much, Patricia. Thanks so much, Glenn, again. Thanks to Simi and Patricia. And David, fue un placer. Necesito hablar contigo un poco más, okay? Have a great day, everyone. Take care. Bye-bye.
Bye.